It's like the flaming, burning pain of 1,000 swords.
Your life basically turns upside down. You don't know what's going on. There's great fear because you don't know. Your body seems so foreign to you now, not like it used to be.
Worked all my life out in the sun. I was a pipeline mechanic, millwright. So I worked outside. Worked out in the sun all my life.
Of course, they all looked at me like I had 3 heads. They really weren't sure, and just basically chalked it up to either sun poisoning or allergic to the sun.
Porphyria, in its different forms, can be painful, frustrating, even life-threatening. But in this video, we'll attempt to demystify porphyria. You'll see and hear patients explain their own symptoms and life experiences. You'll hear from doctors who've devoted their careers to understanding and beating this disease. They'll explain the different porphyrias, including how each one is diagnosed and how each can be effectively treated. And you'll see how porphyria is being challenged, both through biochemical means and through DNA diagnosis, with the hope of novel therapies in the near future.
We've learned a lot about porphyrias in the last 20, 30 years. We know that they're all due to deficiencies of enzymes in the heme synthetic pathway. And we know that there's a type of porphyria associated with a deficiency of each of the enzymes in that pathway. The features of each of the porphyrias depends on which enzyme is deficient. PCT, or Porphyria cutanea tarda, is the most common human porphyria. It's also the most readily treated. It's called cutanea because it affects the skin, and tarda because it tends to occur late in life, either in middle age, usually in middle age. It causes blistering skin lesions, most commonly on the backs of the hands because that's the most sun-exposed part of the body. And these tend to be chronic.
Well, when I first got it, I didn't know what it was. I went to a dermatologist up in Houston. At that time I was working in Houston. Went up there, they didn't know what it was. So I went to a blood doctor. They couldn't figure out what it was. And so we heard about, my wife met this one lady that knew Dr. Anderson. She said, if you can get a hold of Dr. Anderson at UTMB, he'll tell you what that is. I called him, made an appointment with him. He said, sure, I'd love to see you. So I come down, he ran some tests. He said, you got PCT.
The disease itself is due to a development of a deficiency of an enzyme in the liver called uroporphyrinogen decarboxylase, or UROD, which is the 5th enzyme in the pathway to make heme. Porphyrins accumulate in very large amounts in the liver, and these then spill over into the blood plasma and are carried to the skin. And when they get to the skin, they're exposed to ultraviolet light, which excites the porphyrins, and they emit energy, and that causes skin damage. If PCT is suspected, the most convenient test to do is a plasma porphyrin determination. And if that's normal, then it rules out PCT. If it's elevated, it indicates that the patient has some form of cutaneous porphyria, but further tests are needed to confirm that it is PCT or another type of porphyria. PCT is treated by repeated phlebotomy, which means removing a pint of blood, as is commonly done at a blood bank, until the amount of iron in the body is reduced to not to a deficient range, but to the lower limit of normal.
They tend to not have any huge amounts of iron. Some do, but most don't. But it's some extra iron plus the normal amount somehow that over time affects the enzyme that's defective to where the enzyme works less well, and the uroporphyrin piles up out in the blood, out in the capillaries, into the skin, and then promoting the photosensitive skin damage.
Went through 13 phlebotomies, and it cleared up. I mean, it just went away. I mean, you had scars, but you didn't have the blisterings anymore,
And when that is done over a period of weeks or months, patients go into remission. The enzyme deficiency in the liver is relieved, and the porphyrin accumulation stops, and the porphyrin levels gradually decrease.
But in PCT, the majority of patients will have more than just too much iron. Many now, it's recognized, have hepatitis C, and then also excess alcohol use is fairly common. It doesn't have to be the worst alcoholic, just generous intake. So all three of these can often be the factors discovered in the patient, and one can deal with those quite okay these days.
Excess estrogen intake is a fourth factor which precipitates the onset of PCT symptoms.
Acute intermittent porphyria, or AIP, is the second most common porphyria in humans. It causes acute neurological symptoms. That means they're symptoms that come on rather rapidly in the form of an acute attack. And they can resolve within days, or sometimes they're much more prolonged. Sometimes the symptoms can be life-threatening, and sometimes they become chronic.
When I was about 18 years old, I had my first very painful attack, and I went into the hospital, but I was sort of thought of to be a hypochondriac teenager. It may seem impossible, but to some people who may not believe this, but the closest I can come is if you took 1,000, no less than 1,000 flaming swords, like the kind you put in a fire and let it just get ripe red, and then stick it in your back or your abdomen. It's usually in the abdomen, or maybe many places, your legs, your back, just wherever it is that's hurting. It's like the flaming, burning pain of 1,000 swords. But when I became 29 years old, the pain was so severe and I was so ill that I ended up going to the hospital. But this time they saw on a pattern of having little bitty brain waves. I won't say seizures, just kind of some tics of some sort. So I was given Dilantin, which is a big, big, unsafe medication for anyone with porphyria. I immediately became horribly ill. Not just ill, but I began having hallucinations. My lungs shut down, my kidneys were shutting down. They catheterized me, and interestingly, out poured this urine that was the color of Coca-Cola. The porphyrins, or porphyrin precursors in the urine, caused it to change this strange color. By the way, porphyrus means purple in Greek, and it has that sort of strange purplish cast, and that's why they call it porphyria. You would see this phenomenon, so to speak, in the acute porphyrias.
Caregivers that know the most, their patients or their loved ones do the best. It's quite a responsibility. It is an adjustment, but it's a very important one, and when you love someone, you make those adjustments, and it works out fine. It's a team effort, but there's a new member of the team that you have to help your wife or your loved one who has porphyria.
What it starts out like, it feels like someone's kicking you in the stomach with a steel-toed boot. It starts out very slowly, and as the attack progresses, it gets harder. I was a healthy person until I turned 40 years old, and then the summer of July of '99, I became very ill. I was in and out of the hospital for the next 6 to 7 months. I would go in for about 10 days. When I wasn't in the hospital, I was in the ER getting pain medication. I lost 32 pounds. And when I went back to my doctor and told him that something else was going on, that I did not think it was irritable bowel syndrome, he did a test. He said it was on a disease that was called Porphyria. It was very rare. He really didn't think that I did have it, but he did want to test me for it. And he did do a test, and it came back positive. Once the sickness had a name, then I knew that there was a plan, somewhere to go, somewhere to start. There'll be like 2 weeks that I feel fine, that I'm going about my life just like it's normal. I look normal, I feel good. And then it'll set in the next 10 days while I'm going through an attack. I'll be bedridden and I'll be sick, and then I'm kind of a hermit in my own home. There's pains and suffering that you never experienced before. Your family goes through a lot. It's just a very confusing time, very scary time.
You know, when your wife goes from 118 pounds to 85 in a month and a half, how do you prepare? All I can say is stay by her side and give her everything she needs, comfort her as much as possible, and try and take care of family life the best way you can. Because if you have children involved, you have to carry on. I've been married 25 years to her. I'll be there by her side. And that's where you have to be.
AIP is due to a deficiency of the third enzyme in the pathway, which we call porphobilinogen or PBG deaminase. And as a result of that deficiency, PBG is the main intermediate that accumulates. It's also possible that heme deficiency in the nervous system may play a role. So one of the biggest research questions remaining is what is the cause of these neurological symptoms?
It's clear that in the porphyria, acute porphyrias, all parts of the nervous system are targeted in various patients differently. But the abdominal pain is so common, of course that's autonomic nervous system disturbance. And a paralysis is uncommon, but certainly can occur. And so it's mysterious.
Well, the main test that we do is urine porphobilinogen, or PBG, and that's a very specific finding in the acute porphyrias. So that test is the main one that should be used for diagnosis of AIP.
The best thing that I've found for me is panhematin. Whenever I go into an attack, I go out to my local hospital. I have standing orders there that my doctor has set. I just give them a call. They keep panhematin on supply for me there, so they give it to me through infusions.
Well, panhematin, it's usually given as an infusion daily, once daily for 4 days. And this leads to more rapid recovery from the acute attack. And it is widely accepted as the most effective treatment for the acute attacks of AIP.
It's important to note that the porphyrias VP and HCP exhibit symptoms similar to AIP and are treated the same. However, VP and HCP are also photosensitive diseases, while AIP is not. Many acute porphyria patients maintain a high carbohydrate diet and receive glucose at the onset of attacks. It's important that they avoid precipitating factors which can be life-threatening, including calorie or carbohydrate restriction, alcohol, and certain drugs. Screening tests for the acute porphyrias are often ordered, performed, and interpreted incorrectly. Sometimes the incorrect tests are ordered. Reliable diagnostic tests can only be performed in a few laboratories in the United States. It is best to have the test sample sent to a porphyria center. This ensures more reliable interpretation of the tests.
EPP is it's the third most common porphyria, and it is completely different from all of the others. It causes photosensitivity, but the photosensitivity is quite different from what occurs in PCT and other cutaneous porphyrias.
Well, they have a defect in that last enzyme of the heme pathway. Heme, of course, is what makes the blood red, but heme is vital in every cell. Well, when that enzyme is defective, a distinctive porphyrin really accumulates in the body. It's called the protoporphyrin.
I started having symptoms of EPP when I was about 13 years old. I went out on a fishing trip, and we were out probably 5 or 6 hours, I guess, and by the time I got to the emergency room, I had no nose. Everything on my face was flat. Eyes were swollen shut. Ears were just about turned inside out. Hands were to the point of surgical gloves filled with water is what they look like. You can't feed yourself. You can't, because your hands are so swollen, your arms are so swollen that you can't do anything about it. And of course, they all looked at me like I had 3 heads. They really weren't sure, and just basically chalked it up to either sun poisoning or allergic to the sun, but really didn't give me any other type of diagnosis, no blood work, anything like that. And so periodically, you know, I could go out and tolerate some sunlight, and then other times just short spurts and I'd start having the reactions.
They do not get much blistering or scarring of the skin, so the disease is often difficult to recognize because the symptoms, what the patients complain of in terms of skin symptoms is out of proportion to the signs, which is what the doctor sees. So there's often a delay in diagnosis of EPP.
To be honest, I didn't know that it was a genetic disease when I had children. There wasn't that much known about the disease at that point. It was very limited as far as any information that I was able to obtain. I feel a little guilty because I have passed this on to him, and unfortunately now I know that he can also pass it on to his children as well. They have a 50% chance of inheriting the disease. I have one child that doesn't have it, who's very fair, very blonde, and he is not a carrier, but Brandon is. So.
Oh, I don't think there's any need to feel guilty, because I guess this disease made me who I am today, and I'm happy for who I am. And it's, you know, it's something you gotta get over, you know. It's an obstacle. Just get right over it. It's no big deal. I guess when I hit junior high, I started junior high band. And from there I started learning to play drums, and then learned to play guitar, and then piano, and so on from there. And now I'm doing pretty well with my band, and so I'm glad where I am right now, and in a way kind of, I guess not happy with I have the disease, but you know, I guess I'm making the best of it.
Diagnosis is primarily made by measuring porphyrins in red blood cells. In this condition, the porphyrins accumulate in the bone marrow, and because the bone marrow produces red blood cells, the porphyrins are also elevated in red blood cells.
We do have relatively effective medication out for years now. It's beta carotene. It's from carrots. It's marketed as Lumitine by the company that produces it. One has to take good dosage of it regularly.
And this does protect them to some extent from photosensitivity. And so that's a useful drug. It is important for patients with EPP to specify the brand name Lumitine. This drug needs to be ordered. It's not available in most pharmacies or health food stores. Other types of beta-carotene should not be substituted because Lumitine is particularly highly purified and was specifically developed for treating this condition.
Well, it turns you very orange after you take it for a while, but once you've taken it for about 6 weeks, it builds up in your body, and it just allows you to go out and tolerate more sunlight and just live a little bit more normally.
We went snow skiing back in '97. Have no skin showing at all. Hats, goggles, mask, gloves, fully covered, just so I can go skiing.
We went on a cruise to Cancun, Cozumel, and Honduras, and we did take precautions, and we took Lumitine. Luckily, neither one of us had any symptoms because we were taking the precautions with the clothing and everything. So.
Yeah, every once in a while, you know, you can take those like 5 minutes out in the sun, take a quick picture, because in the picture I'm hiding my hands, so I wouldn't, no sun would hit me, and then I'm back in the shade again.
I know I used to love to go to the beach, but after you have the symptoms that we have with EPP, the swelling, the burning, the excruciating pain for a week or so, those things no longer look attractive, and so you find other interests that you enjoy. I think you learn to adapt. You just you know your limitations, and you plan for them, and knowing what makes you uncomfortable and what makes you what will allow you to be comfortable, and just taking those precautions.
Well, if someone thinks they may have porphyria, the best thing to do is to call a porphyria center just like ours. What we would ask them to do at that point to gather up all the available information, especially tests like laboratory tests and some doctors' comments, recommendations they may have, and send it to us, fax it, mail it to us, and if needed, we'll make some recommendations whether or not they need to send some additional samples to our laboratory, to our center, for performing some more porphyria testing to make it easier and more complete.
This lab is accredited by the CAP, that is a College of American Pathologists. Once 2 months, we send unknown samples to the proficiency test centers. So that means make sure we generate accurate and, of course, precise results of the test.
The APF website lists a few other laboratories that perform biochemical testing.
When we moved to Mount Sinai in New York in 1977, our goal was not only to purify the enzymes, but in addition to identify and clone or isolate the genes causing these diseases. Our group, together with other groups in the world, have now isolated and characterized each of the genes responsible for the 8 different porphyrias. With a significant grant from one of the members of the American Porphyria Foundation, we were able to set up DNA diagnostics for each of the porphyrias. So in families where a definitive biochemical diagnosis of a patient has been made, we can now offer DNA testing, because we can identify in that individual the gene that runs in the family. And then we can offer DNA testing to the other members who may be at risk but have never had manifestations.
At Mount Sinai, we don't see patients personally. We only do DNA diagnosis, and on a research basis at the present. And we only do DNA diagnosis on individuals who have some fairly good biochemical data suggesting that they have a porphyria. So that when patients call me, or doctors, I suggest that they contact first Dr. Anderson, Carl Anderson at the University of Texas in Galveston, who runs a biochemical porphyria lab, to have biochemical studies done to try to determine if they have a porphyria, and if so, which porphyria. Then we will decide whether we will do DNA diagnosis.
DNA sequencing is the gold standard for mutation detection, which unfortunately makes it the most expensive technique as well. But fortunately, donations from the foundation make it possible for this to be a routine technique here in the lab.
This machine was donated by a member of the American Porphyria Foundation, and it's one of the newer models, and it allows us to do this amplification of the DNA faster and to do more samples at once. So it helps to speed the diagnosis of patient samples, and we're very grateful for him for the donation.
Well, this room is our DNA core. This is the room that does all the DNA synthesis
and all the DNA sequencing so that we can characterize the mutations in the different porphyria-causing genes. And we use these very sophisticated machines to actually sequence the genes. And this core has over $1 million worth of equipment, which was obtained through research grants from the NIH and from the support of the American Porphyria Foundation.
One of the gratifying things about being involved in porphyria diagnosis is the ability to tell individuals that their relatives are not at risk for having porphyria. They're afraid that their children, all their children have it, or their relatives have it. And by DNA diagnosis, which is usually very reliable, we are able to tell them who is at risk and who is not at risk. And it reduces the anxiety in families who have porphyria a great deal.
It's satisfying to me personally to know that we can tell a patient what the underlying cause is of their disease, of the porphyria. We can give them a precise molecular diagnosis and hopefully potential new therapies.
Today we're very excited about the advances that are being made in porphyria. We have the ability to do precise diagnosis. We never had that before. We really have taken a leap in that respect.
What's hopeful for porphyria patients is the advancement in knowledge about the basic defects in these conditions, understanding the enzyme deficiencies and the mutations. I think that's very important and has a lot of promise for developing future therapies.
There is unfortunately a lot of misinformation about porphyria on the internet, and patients and their families should be careful about which sources they accept as correct. And I would urge them to rely more on the American Porphyria Foundation's website, because they have a board of directors made up of experts in porphyria.
I joined the American Porphyria Foundation in 2001. One of the best things that I've gotten from the foundation is I've met other people that have the disease. And we share experiences and share knowledge and information about the disease, and it's really been a great thing for me.
There's people all over the world, London, Europe, all over. China, they have PCT, they have the other forms of porphyria. And it's just like a website. We get on and talk to each other. It's like a help room, you know.
American Porphyria Foundation, this is Jenny. May I help you?
Well, through the Porphyria Foundation, which I founded along with another gentleman, we wanted to establish an agency that could not only enhance awareness and education, but provide hope. And so when I speak to patients, the first thing I do is say, I'm up and about and running the foundation, although much of the time now it's from home, but I can sure give you hope for a good life. Hi, I'm Desiree Lyon-Howe, Executive Director of the American Porphyria Foundation. I'd like to thank Ovation Pharmaceutical for supporting this most important video on porphyria. Janine Shabas, thank you very much.
Desiree, we're more than happy to help at Ovation Pharmaceuticals with your efforts to educate people everywhere on porphyria.
For more information on PCT, AIP, and EPP, as well as the less common porphyrias, CEP, VP, HCP, HEP, and ADP, please contact the American Porphyria Foundation. Desiree Lyon-Howe's autobiographical experience with porphyria is also available through the foundation.